So Mike asked me to talk specifically about the elderly distal radius fracture, so I'm going to concentrate on that exclusively. And I thought I'd talk just a little bit about what we do in Edinburgh as a routine, and we all have a fairly consistent way of looking after these, and then go through some of the evidence that sort of defends potentially that mentality. So I'm going to talk exclusively about the Colles fracture, because I think that's what we're all probably most interested in. I'm not going to talk at all about partial articular fractures. I'm not going to talk at all about fractures that head volarwards, because I think they're a very different category. So we're talking exclusively about the distal radius Colles. So what happens in Edinburgh? A little old lady falls in the street, she breaks her wrist, she's seen an A&E, she gets some x-rays, and those x-rays, if they show a displaced distal radius fracture, she's placed into a back slab and sent home and brought back the next day to A&E, where she has a Beers block by an anaesthetist and has the wrist pulled in A&E by a senior A&E member, either a consultant or senior registrar, and they place them into a cast. They're then referred to our virtual fracture clinic, and if the consultant at that stage has any concerns, they're brought back early, but otherwise they're seen at 1 week and then 2 weeks. If after 2 weeks the fracture remains nicely reduced and undisplaced, they're treated conservatively in a cast. If, at any point in those first couple of weeks, the fracture displaces, then we start to consider, is it worth doing anything for this patient? And the thing we look at first, when considering whether or not we're going to do anything for a patient, are the patient factors. So if you look at a patient and they've got dementia, they're a nursing home resident, they get home care, they get meals on wheels, they've got COPD to the extent where they can't get up a flight of stairs, we're probably not going to do much to those patients no matter what the x-ray looks like, because it's not really going to benefit them. You've got slightly softer contraindications like diabetes, if it's poorly controlled, and other comorbidities that you can look at. But in Edinburgh, I'm sure as in everywhere, we have the bridge-playing ladies of Edinburgh who are slightly more demanding than that, who want a little bit more done for themselves. They're fiercely independent, they don't want to lose that independence. They cook for themselves, they clean for themselves, and they live at home. And in that group, maximising function for them may be of benefit. What about age? Well, clearly you're not going to fix a distal radius in someone who's 121, but I don't think we have any real handle on what constitutes an elderly patient, what constitutes being too old to have an operation on your wrist. So yes, it's another factor that we look at, but I don't think I could honestly say if you're over 80 or under 80 or whatever number you want to choose, it defines exactly what we do. So what about the fracture factors that we talked about earlier? There's all the usual radial inclination, volar inclination, articular step, articular gap, distal radioulnar joint dissociation, and yes, I look at all of those, but in the elderly group, realistically I'm driven more and more by whether or not they have radiocarpal malalignment. Why do I choose that? Because it's simple, it's easy, it's reproducible, and it doesn't rely on good x-rays either in A&E or in the radiology department. And it makes good mechanical sense to me. If the wrist is off the back of the forearm, then the mechanics of that wrist are likely to be worse. So then have a discussion with the patient, and I think this went back to what we were talking about earlier. It is all tailored to what the patient wants to a certain extent. And I talk to them about plate versus cast. And so I say, with a plate, I can make your wrist look straighter, if you care about that, which you probably don't. I tell them, with a plate, you're much more likely to maintain your grip strength. I say that I reduce your chances of losing supination of your wrist. Now, I don't think old patients really care at all about losing flexion extension, but they do care about losing supination, because that matters for carrying trays, opening doors, wiping your bum. It really matters. I suggest that if we plate it, you'll get back to your function quicker, which may be important, particularly in the patient who potentially is going to struggle with one limb out of action. But, of course, there's a risk of infection, nerve injury, there's plate problems, and you've got to have an anaesthetic, which many old people really want to avoid. And I do talk to them about risk of tendon rupture, although I believe that's relatively low. Or I can treat you in a cast, where we'll avoid an operation. Your wrist might well be fine in a cast, and you might get back to absolutely perfect function just treated in a cast. But I think you've got these other problems with grip strength and losing potentially some supination. And at the end of that discussion, usually they've gone to either, oh, I definitely don't want anything, doc, and you go, fine, or they say, I really want something done, or occasionally you have to chat things through in a bit more detail. If they want something done, I treat them with a simple volar plate. I think in the elderly group, I don't go for any kind of fragment-specific fixation, and I'm really looking to maintain that mechanical alignment for them, as well as maintaining their length. Post-operatively, They go into a Velcro splint, they have their bulky post-op dressings reduced at 2 days, and I'm really vehement with them in the recovery room and afterwards that they can get this wrist moving. It has been fixed enough for you to now use, and I say to them, because I think it's something they can visualize, you can do all your day-to-day activities right now, up to and including the weight of carrying a cup of tea. And I tell them for the first 2 weeks, you can take your splint off whenever you like to do some range of motion exercises, and after 2 weeks, you can get rid of the splint during the day, but you wear it at night, and you wear it when you're out and about and worried about getting knocked or bashed. But otherwise, you take it off, so I really want them to get that wrist moving. And then at 6 weeks, I want that splint off full time. And I think that maximizes their chance of getting back to function quickly. So is there any evidence for all these claims that I'm making to patients about one treatment versus another? And as we've said this morning, actually there's very little good evidence that's been powered to look at operative versus non-operative intervention in the highly functioning elderly group. So what there is has already been mentioned a little bit. We have this study by Eagle, case control study, looking at volar plates versus doing nothing. And his chief difference that he found was grip strength. Clinically and statistically significant difference in grip strength. The prospective study by Aurora, looking at plates versus doing nothing. Once again, grip strength is better if you plate them than if you do nothing. And actually, this is fairly, although not 100% consistently, reproduced when you look at volar plating versus K-wiring, that grip strength is better in the volar plate group. What about my claim about supination? I have less quality evidence for that, I have to admit. So Eagle's case control study, he showed better supination in the operated group. That wasn't backed up by Aurora. And in studies looking at K-wires versus fixation, it's fairly mixed picture, although it does come out fairly regularly. So I've mentioned K-wiring a couple of times there. Why am I not offering my patients K-wires? I think the literature is full of reviews like this, and this is specifically in the elderly group. I'm not talking about youngsters at all. In the elderly group, you can have box charts like this that show matching means for the two groups. K-wires versus volar plates, the mean is the same. But if you look at the tail, with your K-wire group, you have a higher chance of ending up with a poor radiological position if you're K-wiring them. And if you look at that with age, the older you get, the higher the chance there is of losing that position that you aimed for intraoperatively. So by the time you're 65, you've got a nearly 30% chance of ending up with a poor radiological outcome if you K-wire that wrist. Now by definition, you're operating on this group surely because you think you want to improve that radiological outcome. So my thinking on these is either do or do not, but don't try. So in other words, if you think that the radiological outcome for that patient is going to matter to them, pick a technique that is going to maintain that radiological outcome. I fully agree that you could say, I don't think that radiological outcome will matter for that patient, in which case don't do anything. Treat them in a cast. What about quicker return to function? This has been looked at fairly extensively. There's quite a few studies that show essentially a quicker return to function, statistically at least, at 6 weeks and 3 months. And by 6 months, it's probably beginning to equalize. And if you look at the meta-analysis on this, 3 months, it's different. And this is 6 and 12 months bandied together. That's disappearing. You can't talk about the distal radius without at least mentioning draft. It's been discussed ad nauseum, so I'm not going to go into it in too much detail. But just in terms of specifically looking at the elderly fractures, just a couple of things. The cutoff for the draft to delineate between young patients and old patients was 50. In most of the other studies that we've looked at, it's been 65. Now, I would argue that John Keating here should not be in the same group of patient category as 90-year-old Mavis, who only just survives at home.
I'm very pleased to hear that.
So 50, so 50 may be a little bit too low. I can't really give a figure. Personally, I think that actually what we need to look at is the functional ability of patients much more than just their specific age. But draft was 50. So draft showed no real difference between K-wiring and volar plating. But when you looked at it in a bit of detail, they did show a slight leaning in the older group towards volar plating being a little bit better, remembering that their study was powered to the whole group rather than the older group. So I wonder if you split that delineation up towards 65, 70, 80, would it actually show any difference? And I don't know that, but it's just a query of mine. And the final thing is the patient-related outcome measures that we're using. If you go onto the websites and look at the PRWE and the DASH score, it says quite specifically, this is for 16 to 65-year-old patients. and they've never really been validated in patients over 65. So I think they're the best we've got, absolutely, but I think we just need to look at them with a slight hint of caution rather than treating them as the absolute gold standard at the moment. And the only thing I could find, looking at them in a huge amount of detail, did show a significant sealing effect, whatever that may mean. Complications from plates? Well, nothing alters your treatment like your own sort of results. The last time we looked at this prospectively was in 2014 as part of a bigger trial. It's only including 46, but we had no infections, no tendon ruptures, and 1 patient with CRPS. But certainly in my clinical practice, we don't see a huge number of tendon ruptures from this. When volar plating first came out, they were quoted at rates of 20, 25% extensive tendon ruptures. I don't think that's true anymore, and I think the tendon rupture rate is much lower. So my conclusions are, I think plating does get you back to function quicker. I think it probably gives you a better grip strength. I think it's got a relatively low complication rate. I think the number of studies that have been powered specifically to look at doing something versus not doing something in the elderly is very low. And I would have concerns about using K-wires in elderly patients, because if you're using something, it's because you must be thinking to yourself that I want to realign that wrist for some reason. So I wouldn't be wanting to pick something that may have such a high failure. Sorry, I nearly forgot. I'm from Edinburgh. I'm not allowed to come and talk about distal radiuses without talking about non-bridging external fixators. So for this study, I did a review of my last 2 years' worth of non-bridging external fixators, and here they are, gathering dust. Thank you very much.